Welcome to the Deep Dive, where we take your source material, pour over the data, and extract the crucial insights you need to be quickly and thoroughly well informed. Today, we are undertaking a really crucial deep dive into a topic that affects every single community in Canada, and that's suicide prevention. Now, we know this material is sensitive, but our goal here is to give you clarity on the national resources and strategies that are actively saving lives. Our mission is to really understand the new infrastructure, but also the systemic challenges that remain, and I think we have to start just by acknowledging the sheer scale of the issue. Tragically, approximately 4,500 people in Canada die by suicide every single year. I mean, that's an average of 12 lives lost every day. And the data shows that 1 in 9 people across the country will experience suicidal thoughts in their lifetime.
Those statistics, they're not just numbers, are they? They represent this immense public health challenge. And for every person we lose, up to 135 other people are impacted by that loss. The ripple effect just touches families, workplaces, schools, entire communities. And the reason this deep dive is so timely right now is that Canada has finally recognized the need for a national, coordinated, and easily accessible point of intervention. We're talking, of course, about the country's new National Crisis Response System, the 988 Suicide Crisis Helpline.
Okay, let's unpack this. Because a three-digit number sounds simple, but rolling it out across a country this vast is anything but. So the Canadian 988 Suicide Crisis Helpline, it officially launched back on November 30th, and it provides that 24/7 support you can call or you can text specifically for people in a suicide crisis. It's supposed to be the mental health equivalent of 911, right? And that ease of access is everything.
It is. And the coordination effort behind it is just massive. It was established by the federal government, but it's led by the Center for Addiction and Mental Health, or CAMH. But what's really unique is its delivery model. It's decentralized.
So not just one giant call center.
Exactly. We're talking about a network of 39 partner centers and agencies across the country. That includes really established names like Kids Help Phone and the Hope for Wellness Helpline, which ensures you have this broad, local, and diverse reach.
And the response, well, since the launch in November 2023, it just confirms how critical this service was. Since then, 988 has already fielded more than 750,000 calls and texts.
That's an incredible number.
It is. It represents nearly 18.5 million minutes of dedicated crisis support. Just an enormous amount of work in a little over a year.
And the support itself is built to be high quality, too. It's bilingual, it's trauma-informed, and it's focused on culturally appropriate care, which is just essential given the diversity of crises across the country. And for anyone listening who might be worried about privacy, confidentiality is paramount. No personally identifiable information is disclosed outside the network, unless, of course, an active emergency intervention is needed for someone's immediate safety.
What I find fascinating is the unseen technical work that was needed for this. I mean, the CRTC, the Canadian Radio, Television, and Telecommunications Commission, they had to actually mandate a change to 10-digit dialing in several regions, places like Newfoundland and Labrador, Northern Ontario, Yellowknife.
Just so the number could work.
Exactly, just so the three-digit 988 number could even function nationally.
Yeah.
That really gives you a sense of the logistical hurdle they had to overcome.
It really does. It highlights the collaboration you need between policy, telecommunications, public health, and we also have some excellent models to learn from. When the U.S. launched its own 988 service in July 2022, they saw their average response time just plummet.
Oh, really?
Yeah, from 2 minutes and 39 seconds down to just 41 seconds. So that kind of rapid scaled improvement shows us that the Canadian system has room to optimize and can really strive for those swift response times.
Okay, so what happens if you call in a crisis and all lines are full? If there's a rollover call, the system is engineered to avoid having someone just wait indefinitely while they're in distress. Responders are trained to use other resources like 211, that public database, to give local community referrals right away. It keeps people connected to alternative, immediate care.
What's fascinating here is how often people who are struggling actually connect with healthcare providers who aren't mental health specialists. Look at this staggering data point. Around 45% of people who die by suicide saw their primary care provider in the month before their death.
Wait, 45%? Nearly half.
Nearly half.
So the frontline defense isn't at all who people think it is.
Not at all. And if you look at older adults, that figure jumps even higher. It goes up to nearly 60%.
Wow.
Exactly. Now, you contrast that with the number who saw a mental health specialist in that same period, and it's less than 20%. This huge gap, it just thrusts primary care GPs, nurses, even pharmacists into this unexpected role of being suicide prevention's front line. They're often the only window we have into a patient's acute psychological pain.
And the leading researchers, they tell us that suicide is almost always about seeking an end to that deep, intense psychological pain, something rooted in biological, psychological, and social factors. So prevention has to address those things.
Right, and the primary care setting is often the best or only place to intercept them. And the good news is we actually have a scalable tool to equip those frontline providers. The Mental Health Commission of Canada, the MHCC, offers a free, accredited online course. It's called Talking About Suicide, Empowering Healthcare Providers, Instilling Hope in Clients.
And it's free.
Free. And it only takes 3 hours, which is incredibly efficient for a busy practitioner.
A 3-hour course that can transform patient safety. That sounds like a major win. What does it actually teach them?
Well, it teaches them to move past the fear of asking that difficult question. It teaches them how to identify risk factors confidently, and critically, how to collaborate with the patient on a concrete safety plan. And the proof is in the results. 96% of providers surveyed after taking the training reported feeling confident discussing suicide with their clients.
96%.
It's a monumental leap in capacity for our entire healthcare system.
That focus on training the front line is so important, especially when we start looking at high-risk populations. Let's zoom in a little on who's being disproportionately affected. Suicide is the 4th leading cause of premature death for males under 75 in Canada. But the most alarming number here is that 3 in 4 deaths by suicide in Canada are men.
And the reports, they clearly outline the cultural and systemic barriers that men face. Stigma that links seeking help to weakness, gender bias in treatment, and often lower health literacy about mental distress. The solutions that are emerging, especially from the North and from organizations like Movember, they emphasize addressing unresolved grief and integrating support through community and family, rather than expecting men to just walk into a clinic cold. They specifically highlight the need for more Indigenous male counselors in the North who really understand that local experience.
Okay, here's where it gets really interesting, though. Shifting to youth risk. Suicide is the 2nd most prevalent cause of death among children and youth in British Columbia.
The research on youth pathways is particularly insightful here. A McGill study identified 2 distinct groups. The first was the early onset group. They showed symptoms around age 12 or 13, and they displayed both noticeable disruptive behavior, the external symptoms that get attention, and internal symptoms like depression and anxiety.
And let me guess.
The crucial, terrifying finding was that parents and teachers routinely noticed the behavioral problems,
But miss the other part.
they completely overlooked the internal emotional distress.
So the very symptom that gets them sent to the principal's office distracts adults from the real pain. If that internal distress is the missed warning sign, how do we train people to look past the visible behavior and ask about the underlying pain?
It requires focused training, really, much like that MHCC course, to recognize withdrawal, changes in sleep, a sudden lack of interest, those subtler signs. And the second group in that study, the young adulthood group, age 20-25, they often showed only those internal symptoms in their teens.
So they flew completely under the radar.
Completely, until a crisis emerged much later. It's a powerful lesson in looking beyond the surface.
And that profound internal struggle is, it's magnified exponentially in Indigenous communities. The death rate for Status First Nations youth and young adults in BC is a devastating 4 times higher than the provincial rate. And this is, as the sources note, just inextricably linked to the ongoing destructive forces of colonization, systemic racism, and trauma.
It really necessitates a conceptual shift. Many communities now focus on life promotion and wellness rather than just prevention. The First Nations Mental Wellness Continuum Framework identifies 4 vital, kind of aspirational underpinnings: hope, meaning, belonging, and purpose. The idea is to build foundations of wellness, not just catch people when they fall.
We also need to talk about veterans, another high-risk population.
Okay.
The statistics are just heartbreaking. Male veterans are 1.4 times more likely to die by suicide, and female veterans are nearly 2 times more likely compared to the general population.
And the timeline of that risk is different too, which is important for targeting intervention.
How?
For men, the risk peaks in the first 4 years after they leave the service.
Oh.
But for women, it peaks significantly later, about 2 decades after leaving military life.
2 decades later, wow.
And the systemic barriers are intense. The military culture itself often equates asking for help with being unfit, so there's huge stigma. And then, when veterans finally do seek help, the programs are often underfunded. They rely heavily on community charity instead of secure government support. One report even noted that the number of individual benefit approvals from Veterans Affairs Canada has plummeted by 60%.
60%.
It just erects these massive accessibility hurdles at the exact moment veterans need stability and support.
Let's pivot to broader system challenges now, beyond the specific groups. One glaring access issue across the country is just simple waiting time. The national average wait time for community mental health counseling is still 22 days.
22 days. Almost a full month for someone seeking help outside of an emergency.
Yeah.
That 22-day wait time is a crisis of its own. And this is precisely why models like Step Care 2.0 are so promising. Prince Edward Island is implementing it to significantly diversify and increase access points.
Using things like telehealth and walk-in clinics.
Exactly. Telehealth, web-based services, quick access walk-in clinics. Newfoundland and Labrador adopted a similar model, and they saw a 67% reduction in their wait times. It just shows that infrastructure change really works.
And infrastructure change isn't just about services, it's also about hard physical infrastructure.
Yeah.
I mean, look at the Montreal Metro. In 2024, suicide attempts rose sharply to 25. That's a worrying jump from the 14 to 18 attempts they'd seen previously.
And the coroners who investigated the 92 suicides between 2015 and 2023, they're sounding the alarm. Their strongest recommendation, based on the evidence, was the installation of platform screen doors, to block access to the tracks.
That makes sense.
But while it's critically needed, the implementation is currently being studied for 2033. Yes. But the key insight the coroners stressed is that research suggests people in acute distress won't necessarily seek an alternative if their initially planned high lethality option is removed. So barriers work. They also pushed for safety ambassadors and better staff training.
Waiting until 2033 just feels like an unacceptable timeline, given the rise in attempts. And some advocates argue that relying on Metro workers for crisis detection is ludicrous anyway. That prevention has to start much earlier. Though it is worth mentioning, the Montreal Metro is running an AI pilot project that's designed to detect high-risk behaviors on platforms before an attempt happens.
That technological approach, it speaks to this systemic desire for immediate fixes. But the Senate committee that was reviewing the federal framework for suicide prevention, they focused on much deeper, high-level policy change. They made 3 key recommendations. First, recognize the huge impact of substance use. Second, create a unified nationwide database for better data. And third, and I think this one is the most profound, replace the framework's language of hope and resilience with meaning and connectedness.
That language shift is profound. Why is meaning and connectedness so much more powerful in this context than hope and resilience?
Well, because resilience often implies the burden is on the individual to just bounce back from trauma rather than on the system to reduce the trauma in the first place.
Right.
And hope can feel completely unattainable during deep psychological pain. But meaning and connectedness, those are tangible community concepts. They shift the focus from individual pathology to collective support and social integration. It aligns beautifully with those life promotion frameworks we talked about earlier.
That brings us to maybe the most actionable part of this deep dive.
Yeah.
The power of conversation. The core message in all the prevention training is definitive. Talking about suicide saves lives. Directly asking about suicidal thoughts will not, and I have to repeat this, will not plant an idea in someone's head. It actually often offers immense relief by freeing them from this crushing isolation.
And if you are going to ask, we need to make sure we use safe, compassionate language. We have to consciously avoid stigmatizing and outdated phrases like committed suicide. That phrase carries the historical implication of a crime.
So instead you say,
Instead, we use neutral phrasing. Died by suicide, or describing the situation as an unsuccessful attempt. It just normalizes the conversation and lowers the judgment.
the approach that responders are taught is say it early, say it often. They give a practical, direct script. You start with an observation. I've noticed you're isolating yourself. You seem to be struggling, and I'm worried.
Yeah.
And then you move to the direct question. When these things are going on, many people have thoughts of suicide. Are you having thoughts of suicide? That moment of directness, coupled with validation, is just essential.
The simple framework that every listener needs to memorize is the TALK acronym for intervention. T is for tell. Tell the person about the specific indications you've noticed. A is for ask. Ask directly if they're thinking about suicide. L is listen. Listen to their pain non-judgmentally, without trying to fix it or minimize it. And finally, K is keep safe by connecting them immediately to resources or supports.
And those resources are available to you right now. The easiest number to remember is 988, the Suicide Crisis Helpline, available 24/7 by call or text. If you are supporting Indigenous peoples, the Hope for Wellness Helpline is available at 1-855-242-3310. And for children and young adults, please reach out to Kids Help Phone at 1-800-668-6868.
And before we wrap up, we should briefly acknowledge postvention. That's the organized support offered after a loss or an attempt. This is so vital because suicide grief is often more intense, sudden, and complicated than other types of loss. Resources like peer support toolkits are available because the bereaved need structured support to cope with the complexity of it all. So what does this all mean? I think it means that suicide prevention is fundamentally a shared public health priority. It requires massive, multifaceted systemic investment. We need better training for primary care. We need the 988 infrastructure to function flawlessly. But maybe most importantly, it demands a cultural and linguistic shift toward openness and compassion.
The key takeaway for you, the listener, is twofold. First, recognizing the subtle signs of internal emotional distress, especially in youth, is crucial for early intervention. And second, having the confidence, the skill, and the knowledge of that TALK acronym to ask the difficult, direct questions. That's an essential skill every single person can cultivate. Seeking help or helping someone connect to resources is always a sign of strength, not weakness.
And although federal funding has been allotted for 988 and infrastructure changes like platform doors are critically needed, the core challenge remains deeply personalized accessibility. The Senate's suggestion to focus on replacing hope and resilience with meaning and connectedness leaves us with a powerful final thought. How can we, as communities and as a society, focus less on fixing individual problems in isolation and more on ensuring every single person feels a genuine, undeniable sense of belonging and purpose right where they live?
That is a powerful benchmark for collective effort. Thank you for joining us on this deep dive into crisis prevention. If you or someone you know is struggling, please use the resources we mentioned, starting with 988. We'll talk to you next time.